For this video, the focus will be on anticonvulsants or antiepileptic drugs or AEDs, which I'll call them moving forward. And these are used for epilepsy, where epilepsy is a chronic condition that's characterized by recurrent unprovoked seizures. So these chronic seizure disorders can be caused by a number of etiologies that I won't get into in this video. But all of these somehow lead to the transformation of a normal neuronal network to one that is abnormal, likely with a loss of these inhibitory interneurons, which we'll talk more about in a little bit, that would normally prevent hyperexcitability within this network that leads to seizures. Now, there are a number of ways to categorize seizure disorders, which you will cover in your discussion, so we won't touch on that here, and I'll leave it up to you to determine which antiepileptic drugs or AEDs are applicable for which seizure disorder. And this should provide a clue that not just any AED can be used for any patient, and a lot of this will come down to their mechanism or mechanisms of action, which we'll get into in a minute. Now, as I said, we aren't going to get into the causes and the pathophys too much because there are a lot of unknowns along with a lot of heterogeneity. So we will just keep it broad and just enough to understand how our AEDs work. So we will start off in the brain with an action potential traveling down our axons, triggering the opening of our voltage-gated sodium channels that allow that influx of sodium ions to further propagate that signal down to the presynaptic nerve terminal, where the signal, if sufficient, triggers the opening of our voltage-gated calcium channels, allowing that calcium influx. And once the local intracellular calcium concentration reaches a specific threshold again, it begins to mobilize those neurotransmitter-containing vesicles. Now, these synaptic vesicles are decorated with a glycoprotein, like synaptic vesicle protein 2A, or SV2A, which is thought to be one of the important proteins promoting synaptic vesicle exocytosis of neurotransmitters, like in this case, where we have glutamate, which, if you remember from the ALS and the dementia videos, this is going to be our primary excitatory neurotransmitter. So once released into the synapse, glutamate will bind its various receptors, like our AMPA and our NMDA receptors, for example, that will allow the influx of cations like sodium and calcium to help start that signal propagation on the postsynaptic side. So once a threshold is reached, our other ion channels will open to keep promoting that action potential downstream. Now, in order to ensure there is an appropriate balance and hyperexcitability does not result or get that excitotoxicity that we discussed in our other videos, we have these inhibitory interneurons that I alluded to before, and these can release GABA, which, remember, is our primary inhibitory neurotransmitter. And when released from GABAergic neurons, this GABA will bind our GABA receptors, like our GABA-A receptors that are linked to chloride ion channels. So once activated, this leads to an influx of negative charge that will act to counteract that positive charge that's propagating that action potential. So once this negative regulation is no longer needed, there is a similar reuptake transporter for GABA, like there was for the other neurotransmitters we discussed before, and this will recycle that GABA back into synaptic vesicles for when the next negative signal is needed. Or GABA can also be used by the enzyme GABA transaminase to generate more glutamate if needed. So moving to our next slide. Now, these are going to be all of our important players for our discussion of epilepsy, where on the previous slide we discussed signaling in our normal neuronal networks. But in epilepsy, following that transformation to an abnormal neuronal network, we have a hyperexcitable state that is driven by glutamate signaling, for example, with an insufficiency of GABAergic signals, and together this leads to unregulated action potentials, causing epilepsy and seizures. So now there are a few general ways in which these signaling imbalances can be targeted, and we can either reduce glutamate or increase GABA. And you will see that all the mechanisms of AEDs we discussed today will do one or both of these things. So this video will be a little different, and you will see why in a second, but basically we will go through all the different mechanism of action options And then we will talk about specific AEDs or AED classes, because the AEDs cannot be as easily categorized in bins as other drugs and drug classes that we've discussed in previous blocks and videos. So first we will discuss mechanisms that will reduce glutamate signaling, and we can do this by starting at the top by first blocking our sodium channels. And we discussed this a bit with diabetic peripheral neuropathy, where these sodium channel blocking AEDs bind these channels and lock them in their inactive state, so they cannot propagate those signals that would release glutamate downstream. So we can similarly block our calcium channels to prevent that calcium influx that's necessary for mobilizing those vesicles. Now, this can either be binding the alpha 2 delta subunit specifically, like we discussed with our gabapentinoids in the neuropathy video, or these agents can just bind other regions of the calcium channel to lead to that blockade. So another component of the cascade that we can target are the SV2A proteins. Decorating those synaptic vesicles that are necessary for that neurotransmitter release. So if we can bind that SV2A protein and block its interaction required for exocytosis, we can prevent that release of glutamate and downstream signaling. So now bridging over to our postsynaptic side. So once glutamate is released, we can also antagonize those glutamate receptors to block its downstream effects. And this can be through either blockade of NMDA, receptor antagonists, or AMPA receptor antagonism. So their ion channels never open and that signal is not propagated. So now this concludes the glutamate side of the cascade. Now let's stay on this postsynaptic side and talk about this opportunity to increase GABA signaling to restore balance in those abnormal networks. So first, we can potentiate GABA by giving agents that bind to allosteric sites in the GABA-A receptors, promoting that influx of chloride ions following GABA binding and counteracting that signal propagation. Like some of the other classes of agents, we can also administer AEDs that inhibit those GABA reuptake transporters, leaving more GABA in the synapses for longer so that it can elicit its effects. And then we can also inhibit GABA transaminases so that any recycled GABA actually makes it into the vesicles for the next time the signal is needed and is not converted by this enzyme in the glutamate, which would be counterproductive in this case. So now moving to our next slide. So now this concludes our GABA arm and all of the possible opportunities for AEDs to restore balance to provide seizure control. So now which agents employ which mechanism of action or actions? And now I will provide two different ways to sort of tackle this long list of AEDs and their mechanism of action heterogeneity. So moving to our next slide. First option here, we have this list of anti-epileptic drugs or AEDs. And I know this list is long and we aren't going to go over each of these in depth with regard to the pharmacologic considerations. We are only going to go more in depth about those mentioned directly. But I did want to give you a more comprehensive AED list and highlight the complexity of AED mechanism of action. And as you can guess based on the color coding, some of these agents have one primary mechanism of action. For example, phenobarbital, diazepam, carbamazepine, ethosuximide. And then others have multiple mechanisms of action, like lamotrigine and topiramate and valproic acid, for example. And it's important to point out that a lot of the mechanisms of action are not entirely understood, but these are how many of these agents are thought to help with epilepsy and provide seizure control. So moving to our next slide. So another way to organize all these agents that is a little less detailed but a little more digestible is with this chart, which will come in handy when trying to get a better understanding of how all these sort of one-off agents work. most of which don't always fall into a class with other agents that share the same mechanism of action. So hopefully between the schematic on the previous slide and this chart, you will have a better appreciation for how these agents work, and maybe even why some will be used for one seizure disorder versus those that work for many types. So moving to our next slide. So now moving on to the important pharmacologic considerations for agents specifically mentioned, and this will include carbamazepine, lacosamide, lamotrigine, levetiracetam, phenytoin, topiramate, and valproic acid. And we will start off with the pharmacokinetic specific considerations. So we will start off with carbamazepine, which is sometimes abbreviated as CBZ. And this is one of the AEDs that came up in Block 4 because it has a number of key considerations. First, it is a narrow therapeutic window agent that has a target window of 4 to 12 micrograms per milliliter. And this is going to require drug monitoring, especially if side effects appear. It's also metabolized by CYP3A4, and it also induces 3A4, so lots of drug interaction potential. And it is relatively highly protein bound at around 70 to 80%. So we're also going to have concerns for drug interactions there as well with other drugs that are highly bound to plasma proteins. So next we are going to jump down to phenytoin, which shares a number of similarities with carbamazepine. So this agent also has a narrow therapeutic window, and this target window is actually going to be even more narrow with 10 to 20 micrograms per milliliter. And adding to this complexity is this agent's target concentration is near or beyond that of the KM for CYP2C9, which metabolizes this drug. This means that at low concentrations, it's going to be first order kinetics, but at higher concentration, the metabolic enzymes are going to be saturated, so we're going to switch to zero order kinetics, where changes in dose do not lead to proportional changes in concentration, and there's going to be a risk of toxicity. So careful monitoring for toxicity and drug levels and looking for drug-drug interactions. Phenytoin is also highly protein bound and also induces CYP enzymes, so lots of drug interaction issues with phenytoin on top of its unique pharmacokinetic profile. Now jumping down to valproic acid, which is sometimes abbreviated as VPA. And now this agent also has a narrow therapeutic window of 50 to 100 micrograms per milliliter. And this agent is also going to be highly protein bound and metabolized by CYP2C9. So we're still going to be worried about drug interactions, but this time it's not going to be a key inducer of CYP enzymes. So we don't need to worry about interactions from this induction of metabolic enzymes. Next, we are going to move to topiramate, which has a bit wider therapeutic window than the other agents we discussed at 5 to 20 micrograms per milliliter. So a fourfold difference, and this may be more helpful for determining adherence or problem solving when toxicity presents, less so for therapeutic drug monitoring. So this agent has a good proportion of renal clearance contributing to its elimination, and it is not highly protein bound compared to the other agents on the slide, but it is classified as a mild inducer of CYP enzymes. But you won't usually find this listed in mnemonics, for example, for big CYP inducers like PS-Porks, which is a mnemonic we mentioned in a previous video. So topiramate, even though it can induce CYPs, it's not going to be to the same extent as most of the agents listed in this particular mnemonic. Next up is lacosamide, which has a few different windows reported. You may see some reference ranges from 10 to 20 micrograms per milliliter, and you may also see some that list anything under 20 micrograms per milliliter as being within the range. So again, this might be more helpful for adherence or toxicity checks, less so for monitoring. So this agent is not an inducer of CYPs, but CYP2C9, 19 and 3A4 do play a role in metabolism. And because we have multiple metabolic enzymes, we have a lot of redundancy, so little risk of drug-drug interactions there with these metabolic enzymes. And we have no significant protein binding, so no drug-drug interactions there either. On this slide, we also have lamotrigine with a wider therapeutic window from 2.5 to 15 micrograms per milliliter, but again, really only useful for adherence and toxicity concerns. Similar to other agents, lamotrigine is hepatically metabolized, but not by CYPs this time, but now through glucuronidation with UGT1A4. And a lot of the agents on this slide that induce CYPs will also induce this enzyme. So there is potential concerns for drug interaction. However, it is only 60% protein bound, so not so much of a concern there for drug-drug interactions with other highly protein-bound drugs. And lastly, on this slide is levetiracetam, which is also very different from some of the other agents on the slide because it is not protein-bound. It is not metabolized by CYPs, so renal clearance, and it is not a CYP inducer either, and has a relatively wider window, ranging from 12 to 46 micrograms per milliliter when compared to agents like valproic acid and phenytoin with their more narrow windows. So because we cannot easily bin these AEDs based on mechanism of action like we usually do with drug classes, this slide highlights ways to bin these agents based on their pharmacokinetic considerations like narrow therapeutic window versus a therapeutic window that can be used more for adherence or toxicity checks. We can also use our metabolic pathways used or induced by the agent to bind them, or degree of protein binding and the risk for drug interactions there. So now moving to the next slide, and here we are going to talk about important pharmacodynamic, pharmacologic considerations, specifically ADRs, that can help group these agents. So some of the common ones across most of these agents will include ataxia, double vision, drowsiness, confusion, all of which you would expect with these CNS active agents. There's also going to be a risk of hepatotoxicity with a number of these agents that utilize hepatic metabolic enzymes, and many will pose fetal harm due to antifolate effects. But obviously there is a balance between seizure control and fetal risk that needs to be taken into consideration. Additionally, those inducing metabolic enzymes can induce enzymes that inactivate vitamin D. So those drugs will come with a risk of osteoporosis, for instance. So now we're going to move on to more specific ADRs for each agent on this slide. So we're going to start off with carbamazepine again. And with this agent, we have a risk of hyponatremia and the syndrome of inappropriate ADH secretion, or SIADH, because it can elevate ADH levels. There is also a risk of aplastic anemia. So checking a CBC will be needed, and this is a black box warning. There is also a risk of Stevens-Johnson syndrome or toxic epidermal necrosis, which can be a fatal skin reaction, and this is also a black box warning. And this reaction is associated with a pharmacogenetic consideration, being the HLA-B1502 allele that we have talked about before. And remember that the downstream product of this actually presents a toxic carbamazepine metabolite to the immune system, and this leads to that skin reaction. So this will come up a few times on the slide. So this is a genetic test that will be needed for those of Asian descent where this allele is most common. So next up is phenytoin, which comes with risks for gingival hyperplasia, as well as hypertrichosis, and also has a slew of allergic type reactions ranging from bone marrow suppression to skin reactions like SJS, all the way to angioedema. Now, going in the same order as before, we have valproic acid, which can lead to alopecia. We can also have tremor, weight gain, and there are several black box warnings. One is for hepatotoxicity, especially in those with mitochondrial diseases. There is also one for pancreatitis. And this should not be used in pregnancy or in patients who plan to become pregnant unless no other agent is effective. And effective contraception should be used in those of childbearing age because of the risks like neural tube defects with this particular agent. Now on to topiramate. And this comes with a slightly different ADR profile than some of the other agents with a risk of weight loss. There is also a risk of kidney stones, metabolic acidosis, and also a risk of glaucoma. Lacosamide is next, which comes with cardiovascular concerns like arrhythmias, and unlike the other AEDs on the slide, it is a Schedule 5 controlled substance, so a risk of misuse. Moving on to lamotrigine, which we will revisit and list that black box warning for SJS and other fatal skin reactions for. And this is why there are very slow titration guidelines to reduce this risk. There can also be a risk of other allergic type reactions as well as cardiovascular concerns. And lastly is levetiracetam, which can also cause some of those allergic type reactions like SJS and other rashes. And also there is a risk of behavioral changes and issues. So you can see some trends amongst these ADRs that may also help you group these agents, and some like the black box warnings that can help you differentiate them as well. So moving to our last slide. So in summary, I hope this video has provided you a good foundation for understanding this very complex class of agents, and that I have provided you with a number of strategies to break down their mechanisms of action, their pharmacokinetic considerations and ADRs, and place these drugs into bins, so that way you can more easily understand how they work in different seizure disorders and what expectations you need to set in your counseling sessions with patients to promote adherence and prevent toxicity. So because unfortunately these agents do come with some troublesome side effects that may cause patient adherence to waver if not appropriately warned, which could lead to poor seizure control and detrimental outcomes. Now, one last thing, I know I did not get into strategies to combine AEDs, but now that you have an understanding of these different agents, you can begin to think about how combination regimens and what may be their advantages or disadvantages, because obviously combining valproic with lamotrigine, for example, will have different dosing considerations than combining phenytoin and lamotrigine because of changes in metabolic enzymes and downstream risk of rash. Whereas combining agents that cause weight loss, like topiramate, with valproic that causes weight gain, this may offset each other and help promote adherence if combo therapy is needed. So these are just two examples of things you should think about when considering AED regimens.